briefly summarize, we shall run through the summary. Medical education restructuring curriculum is a vision. It is a proposal made by an ordinary citizen, which needs to be looked, which I hope and I vision and I pray that the government, they take cognizance of this particular curriculum, which has been presented in multiple parts and multiple segments. MERC begins with the introduction of preclinical sciences in 11th and 12th standard, which consists of human anatomy, human physiology, human biochemistry, and community medicine, which are essentially the first MBBS portion, in lieu of physics, chemistry, botany, and zoology, which are absolutely unconnected, unrelated, and non-applicable subjects as far as first MBBS, as far as MBBS is concerned. And we would do well if preclinical sciences is introduced in 11th and 12th standard, which would lay a very super strong foundation for the MBBS. And more importantly, it would harness 2 precious years of academic time instead of utilizing it for those subjects which are inapplicable and which would only be discarded after completion of 12th standard, namely physics, chemistry, botany, and zoology. MERC extrapolates this same concept to the second year MBBS portion also, namely the pathology, the pharmacology, microbiology, and forensic medicine, which are known as paraclinical sciences. Post 12th standard, MERC envisions that we would do well to have a 2-year course known as paraclinical sciences. What is envisioned as the future of pre-medical education in India or pre-MBBS education in India, which is nothing but which is named as 4-year PMIC, that is 4-year pre-medical integrated course. After 12th standard, once anatomy, physiology, biochemistry, and community medicine foundation has been laid, a student who is not interested in going to MBBS has a huge array of options in the fact that he or she can go for general nursing, BSc nursing, BSc Allied Health Sciences, BSc Microbiology, Ayurvedic, Unani, Siddha, Health, Homeopathy, and the entire gamut, the entire umbrella of courses, he or she would be most welcome to D-Link after 12th standard. And the greatest advantage would be that 2 years of preclinical sciences would give a huge confidence and a great academic foundation upon which they can sail through the further courses which they have joined. Having thus mentioned about pre-medical integrated course, MERC has also introduced 2 other important courses, namely the pre-veterinary sciences, extrapolating the same concept to the students who wish to enter veterinary sciences, take veterinary sciences after their 10th standard. Instead of the same inapplicable quartet of subjects, namely physics, chemistry, botany, and zoology, we would do well to introduce pre-veterinary sciences, which would consist of obviously the first year BVSC portion, Bachelor of Veterinary Science and Animal Husbandry, BVSC and AH as it is known as. It is envisioned that the 11th and 12th standard for pre-veterinary sciences would consist of the BVSC portion and of course advanced zoology. MERC also has extrapolated the same concept to agricultural sciences. There are two important visions that MERC would like to propose. One obviously is the introduction of pre-agricultural sciences, colleges of pre-agricultural sciences, colleges of pre-veterinary sciences, wherein the first year portion or second year portion, both of BSc Agriculture, would be fast-tracked and would be taught in 11th and 12th standard along with advanced botany for those students who want to enter the agricultural sciences. This is vision number 1 of MERC. MERC also has proposed an extremely important change with regards to agricultural sciences, BASc, on the similar lines as BVSc, a 5.5-year course from which students who pass out would come out as doctors of agricultural sciences. MERC also proposes the introduction of BSc and MSc medicine, which are aimed at bringing out quasi-medical professionals who are trained at par with, they would not be equal to MBBS, but they would be receiving a huge amount of training, both theoretically and practically, especially towards skill and patient therapeutics in delivering the goods as far as the patient are concerned, whether it is investigation, whether it is treatment, whether it is therapeutics, practical, bedside, intensive care. BSc and MSc medicine are being proposed by MERC as two degrees, graduation and postgraduate degrees, with the particular aim of filling in the lacunae or the gap or the want or the deficiency of MBBS doctors in the rural areas. The BSc and MSc medicine graduates and postgraduates would do well when they are deputed as health officers or junior health officers, senior health officers in the rural areas, which are very much in need of trained professionals. MBBS doctors, of course, might not be present at every rural setting. MERC further goes on to address an extremely important problem that our nation is facing, and that is the rising costs of medical education. We all know about it, and what is the solution that MERC has offered? MERC believes in the 4-year pre-medical integrated course, wherein the first year and second year of medicine would be completed in an extra-medical college environment or in a outside the medical college platform, namely the College of Preclinical, College of Paraclinical, or in toto, College of Pre-Medical Sciences. The students would have completed both first year and second year portion for not just 1 year but 2 years each, in contradistinction to the 1 year first year MBBS and 1 year second year MBBS. PMIC, pre-medical integrated course, leads to a 2-year and 2-year, a 4-year super strong foundation, absolutely high standard of teaching, from where students would then, it is envisioned, it is MERC's vision, that they would enter MBBS directly in the final semester or the final segment. So this would hopefully lead to the creation of a 2.5-year MBBS course, with the first year consisting of education, evaluation and examination of whatever has been learnt thus far, along with the initiation of clinical medicine, clinical practice, clinical hospital-based teaching, etc., along with, of course, the ENT ophthalmology group of subjects. And of course, the final year, as usual, will be 1.5 years, wherein the core subjects, medicine, surgery, obstetrics, gynecology, pediatrics, dermatology, psychiatry, emergency medicine, anesthesia would be taught, along with orthopedics. And of course, after that, there would be the house surgency or the internship. Therefore, the envisioned reduction of the entire course, the 5.5-year course of MBBS, when reduced, if found possible by the authorities that rule our nation, if MBBS course as such is reduced to 2.5 years after a 4-year solid PMIC, then the cost of education would obviously come down. So, this being the case, post MBBS, MERC further continues its vision of post MBBS, the examination scenario. There are 4 exams: the final year theory, final year practical, the All India Postgraduate Medical Entrance Examination, and of course the post MBBS licentiate examination, which are known by various names. MERC proposes final MBBS theory examination as being the most important and the major platform for evaluating the true academic potential, or the quantum of education, the quantum of training, the quantum of teaching that the MBBS student has imbibed, assimilated and absorbed over these years. How do you know that? It is not by an MCQ examination. MERC does not favor the replacement of final year MBBS theory examination by an MCQ examination. Every system questions would be asked. Right from preclinical, paraclinical and clinical, questions would be integrated. Newer research methodologies, one section would be devoted to that. Recent advances, one section would be devoted to that. And last but not the least, the pass percentage at present is 50%. You want to upgrade an examination, increase the pass percentage to 60%. Then the students would be on their toes and would not take this exam lightly as just a pass and forget examination. MERC goes on further to suggest regarding the final MBBS practical examination, that is the fourth professional practical examination, which MERC feels should not be a huge affair with one long case, three short cases with four external examiners, that, this, etc. No. Only to filter out the most underperforming of the student. The same super detailed practical examination MERC feels would be most appropriately positioned at the end of house surgency, wherein the student would have gone through all the departments. He or she would be posted 24 hours, 24 by 7 into 365 days. The house surgency is a full-fledged program, is a full-fledged committed program. Therefore, at the end of 1 year, when we want to know what is the total knowledge, both theory, practical, clinical, as applied to the patient, the entire works, we want to know, that is the time where we need to position the final MBBS practical examination after house surgency, which would be nothing but the licentiate examination. Moving further on, MERC has proposed an extremely innovative format of All India Postgraduate Medical Entrance Examination, and that is subject-specific All India Postgraduate Medical Examination. A person who wishes to apply for orthopedics, he or she would be asked questions only in orthopedics, of course, with anatomy, physiology, biochemistry, and pathology, microbiology, and pharmacology of orthopedic diseases, along with the regular classical orthopedics. In other words, the present system of 21 subject All India Medical Entrance Examination, MERC feels, must be discarded, must be replaced by a All India Postgraduate Subject Specific Entrance Examination. Moving further on, MERC has brought about has suggested certain changes in the training program of surgical postgraduate surgical registrars, both at the specialty and super specialty level, by way of the introduction of a national surgical logbook, in which a stipulated number of cases, at least 70 to 80% of the stipulated number of cases, must be done. The postgraduate must be given hands-on surgical opportunity and must be made a competent surgeon before obtaining the degree. The compulsory rotation through units, if multiple units are present, to make sure that stagnation does not occur. The proposal of appointing mentors to train, to oversee the training of these postgraduates, and the formation of an apex body, which would be known as, it is visioned that it will be known as Surgical Society of India, which would be an apex body which would ensure that surgical trainees get appropriate training. At the same time, the surgical trainees, the surgical residents also would be absolutely obedient, respectful, and diligent, hardworking, sincere, and committed to patient care. In order to ensure this, MERC feels that an apex body is required, which would 6 monthly or yearly, annually, whatever it is, it would interact with both the PGs and faculty to know whether the PGs are getting a fair deal as far as surgical training and surgical exposure is concerned, and at the same time interact with the faculty to know how the PGs are faring, whether they are being indisciplined or whether they are working as per the requirements. This being the case, MERC also has brought out an extremely important suggestion, and that is the final exit examination, or what we call as the final PG examination, both at specialty and super specialty, that has to be conducted with all 4 external examiner panel. All 4 external examiners, the student would be passing purely on his or her own merit. Most importantly, this would lead to a uniform system of examination all over the nation. MERC further goes on to very strongly propose the scrapping of the degree known as Diplomate of National Board, both at the specialty and broad specialty level, DNB and Dr. NB for specialty and super specialty, and instead MERC proposes or strongly goes for a pan-India, all-India, uniform degree and a uniform medical education. MERC strongly feels that there has to be only one degree all across. The degrees cannot be discriminated based on where the student has received his or her 3-year training. The 3-year training needs to be standardized. It is not that just because a student comes from a center recognized for DNB, he or she gets a degree known as DNB. As MERC has already mentioned, DNB is not a degree, it is a diploma. The word diplomate, technically, legally, and as per the English dictionary, it means a person who is holding a diploma and not a degree. And also, last but not the least, two students receiving the same training, reading the same textbooks, reading for the same degree, taking the same 3-year course, one gets a master's degree, another gets a diploma degree or a diplomate. Why are we having these multiple names? This is unfair. When we look at all other courses, whether it is BE, BTech, MBA, CA, BCom, MCom, BA, PhD, whether a student does it in one state or whether he does it either in Kashmir or whether in Kanyakumari, whether a student does it in the west or in the east, whether a student does it in the university or in an open university, there is only one degree that is given. All over India, medical field needs to have only 2 degrees, MD, MS at the broad specialty level for medical and surgical honor, and DM and MCH at the super specialty level for medical and surgical super specialties. So, this being the case, MERC further goes on to introduce the concept, a much needed concept of surgical accreditation examination. A student who comes out of an surgical specialty or broad specialty has come out after, no doubt, a 3 years of so-called rigorous training. But at the end of the day, there would be a question which is not unfair, which is not unjust, and that is, how does the society, whether it is the patient society or the surgical society or the medical society, how do we know that that particular student is capable of operating? How do we know the technical capability, professional capability, on-table performance? How do we know that? Nobody knows that. It is assumed and presumed that he or she has received a 3-year training. But as we all know, all 5 fingers are not the same. All institutes cannot give the same amount of training. Therefore, in order to ensure that there is an unequivocal, unambiguous proof of a surgeon's ability, what MERC proposes is the implementation of a surgical accreditation examination, which is, to put it briefly, 1, it is not obligatory, it is not mandatory, it is voluntary. All that accreditation examination is nothing but a surgeon would post a case and operate the case with his or her own team on a particular given day, and a surgeon who is designated as an accreditor, who is obviously a very senior person, that surgeon would come and physically watch the proceeding, both the pre-operative, the operative, the intraoperative, and the post-operative proceedings, and once satisfied that the surgeon truly has displayed a reasonable amount of skill, technical on-table skill, and of course the post-operative management, etc., that particular surgeon would be given the seal of accreditation, which would go a long way in establishing unequivocally the surgeon's expertise. Surgical accreditation would lead to a stronger credentials when a surgeon approaches a particular hospital or an institute for employment. These are, in brief, the advantages of surgical accreditation. Apart from individual surgical accreditation, MERC also proposes departmental accreditation, where institutes or even whether it is corporate hospitals, whatever it is, the department's result as a whole are looked at, are tabulated, and a departmental accreditation is given, wherein it would help to, wherein all this would help for introspection, retrospection, self-evaluation, and correction of deficiencies to improve ourselves, for the surgeons to improve themselves. And a better surgeon would lead to better surgery, would lead to better outcome, and would ultimately benefit the patient. And last but not the least, MERC proposes a concept of annual surgical audit. So annual surgical audit would once again help the surgeon to define where he or she stands and ensure that he or she gets to correct any deficiencies or improve upon what he or she has already built as a foundation. So the accreditation process would summarize the process of accreditation: individual accreditation, departmental accreditation, post-annual surgical audit accreditation, and last but not the least, the already prevalent NABH accreditation, National Accreditation Board of Hospitals. So all these four put together would give a extremely unambiguous seal of accreditation and authenticity. It would authenticate the Indian surgeons' ability and performance in the eyes of our nation and internationally also. Last but not the least, MERC proposes the rural healthcare services. As already said, the government is taking huge steps in improving the rural healthcare services program. But MERC feels the MERC has only a very small proposal, and that is the introduction. Just now we have mentioned about the BSc and medicine, MSc medicine postgraduates who are highly trained, highly skillful, quasi-medical professionals who can perform almost independently. However, they would be performing under supervision of a nodal center or a referral center, which would be a specialty hospital within the vicinity of the rural area. So in a combination of BSc and MSc health professionals, graduates and postgraduates who would be appointed as health officers in rural areas, they, along with a combination of telemedicine and nodal centers, referral centers, they would be able to provide the much needed quality healthcare in rural areas, where it might not be possible for MBBS doctors to be there in each and every segment of our geographical segment of our nation. As we come to the conclusion, what is all this about? What in core that the government has? One is inclusive India. Take everybody together. One. And two, knowledge India, skill India. How does MERC achieve these goals? As a part of Inclusive India program, MERC, by introducing the single academic strategic maneuver of introducing preclinical sciences in the 11th and 12th standard, would ensure that every student who enrolls in 11th and 12th standard, post 12th standard, no matter where the student branches off, the student may go towards Ayurvedic or Unani or Siddha or homeopathy or nursing or any other allied healthcare system. But if preclinical sciences is introduced at 11th and 12th standard, every student across the country would be having a uniform pattern of education, and that is, they would all be studying human anatomy, human physiology, human biochemistry, and human community medicine. which would provide a uniform foundation, they would still be united as far as the foundation is concerned. Therefore, this is how inclusive India concept is achieved by MERC's proposal, by hopefully, if the government finds it acceptable, by implementing these proposals, this is how inclusive India strategy would be achieved. Knowledge India and Skill India. The government has taken huge steps to promote Knowledge India, because that is what will lead to Skill India. When all those professions are receiving a focus on practical trainings, skill training, etc., medicine, surgery, which are one of the greatest professions of mankind, which deal directly with cutting open a patient, should they not receive skill training? Should skill not be an extremely important agenda of the surgical profession or medical profession on the whole? Yes, it should be. And how does MERC hope to achieve it? By introducing of surgical accreditation examinations, which has thus far not been proposed by any body. The introduction of a rigorous, diligent, goal-directed PG training program at the PG level, both specialty and super specialty, by introduction of accreditation examination after obtaining of degree, by continuing surgical education, by making sure that apex body like a Surgical Society of India would periodically review the performances, by conducting of annual surgical audit. These are the ways we promote skill, whether it is medical skill or surgical skill. That is not, we are not discussing. This is how India has a great opportunity to become truly Skill India, Knowledge India, Knowledgeable India, Skill India with regards to medical profession. So, with this, we come to the end of this rather long, multi-segment, multi-part, multi-capsule presentation. As I have always maintained, I'm an ordinary citizen. I'm just a cardiac surgeon. There are hundreds and thousands of doctors, teachers, consultants, faculty, all across our nation. There are thousands of them who are more knowledgeable than me, who are better academicians, who can design better educational and academic strategies better than me. I, as a very ordinary individual, I have only attempted to put across to the nation, to the society, to the student society, to the medical society, to the surgical society, and of course to the government, to the powers that rule our nation, a particular strategy, a particular group, a set of strategies, which is known as medical education restructuring curriculum. I request them to view this program. No subscriptions, no icons, no pressing of bell buttons. No, nothing is required. I do not expect any of those. I don't want any of those. All that I request, only view the program completely, this multi-part presentation, and give your valuable opinion. And I hope, lastly, I hope and pray that the government takes cognizance of all that has been said, all that has been proposed. And I hope and fervently I pray and envision that the government finds a meaning in this proposal, in this curriculum. And I hope that it takes steps to implement this and make India the greatest nation in this entire world as far as medical education and medical therapeutics is concerned. Thank you.